Mr. Fam, Dr. T here. How are you doing on this freezing Wednesday afternoon? Oh my goodness. Hands up, who else is absolutely over winter? I have just about had enough. And I know it's not snowing, and I know there have been glimpses of sunshine today, but seriously, that wind is so ridiculously cold. So, yep, I'm over it. We are coming into August very soon. Thank goodness it's the last month of August, the last month of winter, and we can get some spring happening. I hope you guys are really good. Are you really good? I hope so. I had a most magnificent weekend with my CREI colleagues in Sydney at our annual CREI meeting. It was fabulous. To those of you who don't know what a CREI is, absolutely go and check out our website, ANZSREI, Australian New Zealand Society of Reproductive Endocrinology and Infertility Specialists. There's probably about 80 of us around Australia, probably just a few more actually. And we are a group of fertility specialists who have spent several years more studying in the area of infertility, recurrent miscarriage, and reproductive endocrinology. So you'll find that most leaders within the field tend to be people who have done CREI. So it was an inspiring weekend. It was uplifting. It was invigorating. It was so nice to get back on a plane again. I had a magnificent time just catching up with all my colleagues, and I had lots of love coming my way. So I have had a couple of questions come through direct message, and feel free, if you would like to ask a question, rapid fire Q&A, drop it into the comments section. As you know, a couple of rules: keep it short and sweet, try and keep it nice and generic, don't need your whole life story, and I will try and give a fairly generic explanation. So feel free to drop it in. But I have had a couple of questions come across direct message. The first one that came across, I'm wondering if you might be asking a slightly different thing, but someone asked me about egg fragmentation and what's the problem with egg fragmentation. Generally speaking, we talk about fragmentation in the context of embryos. So I'm wondering if that's what you're meaning. That's what I'll talk to. So fragmentation in an embryo is when a small fragment of usually cytoplasm, so the kind of the extra bits around the nucleus of the egg, is extruded as those cells are dividing and dividing and dividing. And so little fragments of cytoplasm are kind of extruded out. And no one really knows why they happen. Generally, it is thought to reflect egg quality, perhaps some mechanism within the egg messaging as it divides and divides and divides, means that there's something that's not quite happening, that's wrong. And so generally speaking, it's thought to be related to egg quality. So if you've got a heavily fragmented embryo and lots of these little pieces, then generally speaking, it speaks to poor prognosis for that embryo. However, recently with the advent of time-lapse imaging, it has enabled our embryologists to examine what's happening between the scenes as embryos are growing. And in fact, some people have shown how some of these fragments have actually been reabsorbed back into the little blastomeres, the little cells, as they're dividing. So perhaps it might not be an entirely bad thing. We also know that just because an embryo is heavily fragmented doesn't mean we don't give it an opportunity. All of us have seen an embryo with very few fragments not become a pregnancy. And we've also seen embryos with lots of fragments make very beautiful babies. So we will always give an embryo a chance with fragmentation, particularly if that embryo is continuing to develop all the way through to that day 5 or blastocyst development. So fragmentation is an interesting thing. Watch this space. I'm sure there are lots of researchers out there looking at fragmentation, but the other really interesting thing is that there are some laboratories who actually go in and take these fragments out because there's a, I guess, belief that it gives the embryo a greater opportunity to grow and develop. But it is a very controversial treatment. So anyway, that's a little bit about fragmentation, if you've heard your embryologist talk to you about fragmentation. Somebody else asked what seemingly is an easy question. I think this is Amy, but is not, in fact, an easy answer. So Amy has asked me to explain the difference in the number of days before an embryo is transferred between an IVF cycle and a frozen transfer cycle, and also if there is a difference between embryos that go to day 5 versus embryos that go to day 6. So it's a very thoughtful question. And certainly I will say that one of the discussion points that we had over the weekend was, well, how many days of exposure to progesterone should that endometrium have, ideally, to get the best pregnancy outcomes? So let me just talk through what happens in an IVF cycle. You get a trigger, and then 36 hours later, before that those eggs have ovulated, you will get your eggs collected, collected, and they, by rights, should be mature. So the trigger does a number of things. Firstly, it helps to mature the eggs so that it enables them to be fertilized. And secondly, if left long enough, those follicles will ovulate. So we know at 36 hours that the post your trigger being given, that it hasn't ovulated yet. However, it is highly likely that there is some progesterone already being released as that follicle luteinizes. So there's potentially at day, let's call it 0, before fertilization, that there's progesterone being exposed to the endometrium, right? So then there's fertilization day, day 1, day 2, day 3, day 4, day 5, and day 5 is when we transfer the embryo. So that's 6 days of exposure. Now, some embryos are cultured through and to day 6. Generally, those are frozen because you'll prefer to transfer on day 5. So in a fresh cycle, generally speaking, it's had 6, sometimes a little bit more exposure, days of exposure to progesterone before the embryo is transferred. Okay, so that's in a fresh cycle. Now let's think about frozen transfer cycles. So we've got HRT cycles where we just give estrogen, and then when we're happy with the lining thickness, we'll expose to progesterone. And generally speaking, with HRT, you put the embryo back on the 6th day of progesterone exposure. Then you've got natural cycles and then modified natural cycles where you get a trigger. So with a natural cycle, it will be your LH surge. So you'll see the LH surge, and then you get plus 6 days of exposure to progesterone. And then with a modified natural cycle, you'll give a trigger, and from the trigger, it's 7 days, because we have to account for that 12 to 24 hours before ovulation. So there is probably a slight difference by up to a day. However, we know the window of implantation is wide. It's not just 1 day. So the window of implantation goes from 6 days to 10 days post ovulation, or 7 to 11 days post LH surge, right? So we know that there's probably some progesterone coming in there. So there is some debate. With a day 6 embryo, generally it will be treated as if it's a blastocyst, which is day 5. It just took a little bit longer to get to day 6. So it will be transferred as if in a frozen cycle, as if it is a day 5 or blastocyst embryo in a frozen transfer cycle. So frozen cycles do tend to lag as far as maturity and exposure to progesterone goes compared to fresh cycles. However, we know globally that frozen cycles do pretty much as well as fresh cycles. And the other thing that is emerging in the literature, that probably natural cycle or modified natural cycle is better for pregnancy rates than HRT cycles. And that's pretty much a global thing now. We also know that it is better for the pregnancy because the presence of a corpus luteum is thought to provide better pregnancy prognostics as far as reduced rates of preeclampsia and preterm birth. So hopefully that's kind of an explanation as to quite a complex area. It's not quite as simple as you thought. Now, I have seen a few questions have come through. Let's have a look. I'm going to just spin myself back. How are we doing, everybody? Oh, lovely to have everybody on. Okay, Tamarine, how many cycles do you recommend after a miscarriage? And do you recommend having a D&C to just have a clean out even if a miscarriage happened naturally? So this is my perspective on this, and others may feel different. But generally speaking, I would allow one natural cycle before trying to conceive again after a miscarriage. There is some evidence, though it's not good quality evidence, to suggest there's a slightly higher miscarriage rates if you conceive directly after a miscarriage. Plus, I think psychologically it's really important for you to do that. And the cycle following a miscarriage is often longer anyway because the HCG levels take a couple of weeks to come down. Would I recommend a D&C to have a clean out unless there's retained products of conception? No, because any instrumentation of the uterus is going to increase the chances of you developing scar tissue and also can compromise cervical competency as well. So I wouldn't just go and have a D&C for a clean out. Okay, Zarpana, does metformin help egg quality? If so, could you explain how? There's lots of aspects of metformin that we don't really understand how it works, but we certainly consider using it in a population of women who have insulin resistance, say a polycystic ovarian syndrome patient, more to change that endometrial milieu, that environment, because we know with insulin resistance or glucose intolerance, you can have quite an inflamed milieu. So metformin is brought in to modify that. We actually also use metformin to reduce the chances of getting OHSS, and the mechanism behind that is largely unknown. So as far as helping egg quality goes, I wouldn't give it as a primary adjuvant to help improve egg quality unless it's with someone in the context of insulin resistance or PCOS. Bex Coleman, when is it too late to freeze eggs? I'm 35 and I'd like to try and have a kid or two in the near future. Get onto it, Bex. We had a fantastic lecture over the weekend by Dr. Eve Feinberg, which kind of solidified what I think I already understand, is that older eggs don't really freeze and thaw as well. We already know that there is a compromise to quality as we get older, so you're going to have to freeze more the older that you get anyway. But a lot of the data coming out of international populations, who are probably a good decade ahead of us, is that those who are freezing at sort of 37, 38, 39, the thaw rate is poorer and the pregnancy outcomes are poorer even when they're using greater numbers. So it's perhaps that they just don't survive that freeze and thaw exposure to those eggs as well. So 35, get onto it, Bex, and I would be suggesting that if you want 2 children, you're going to have to think about having more than 20 eggs in the fridge. Probably, you'll need 15 to 20 to get 1 child. So you might need a few cycles. Off you go. Get onto it. Okay, Emma's Punter, how to stop getting follicular cysts over 10 centimetres in size. Well, it depends what these cysts are. If they are truly follicular, the follicles, then the combined oral contraceptive pill will help to suppress follicular development. Some women will get persistent follicular cysts if they're on progesterone-only contraception, the Mirena, the Implanon, for example, because of the progesterone-only nature and the feedback to the brain. So, yes, you will have to suppress them, and the best way to do that is with the combined oral contraceptive pill. That's if they are follicular cysts. Any more questions? Any more questions? Can't see any more. These were great. If you've got any last minute questions, please don't hesitate to drop them in. We had a fantastic debate on the weekend, which was such a joy to be a part of. I know Dr. Alison G, who I think has jumped on here, was on the panel with me. And we had on my team, we had Dr. Jason Abbott, who is a specialist ages laparoscopic surgeon, and Dr. Rebecca Deans, both of whom were involved in the first uterine transplant here in Australia. And Dr. Deans has worked tirelessly for over 10 years to advocate for uterine transplant to happen in Australia, and she's been around the world studying it. I guess I was involved just because I see a lot of pediatric adolescent gynecology patients and patients who have a syndrome called MRKH, where they don't have a uterus, but they've got ovaries. So it would be nice for them to be able to experience childbirth, versus the opposition. We're looking at gestational surrogacy, which is an option for many people who have either weren't born with a uterus, or perhaps have had an operation to remove it for some reason, or might have even had Asherman syndrome, which is scarring of the uterus. And so we debated the pros and cons, and it was a really fantastic, enlightening debate that went ahead. So it was really good. Okay, I have had a question come through. This is going to be my last one. Hey, Dr. T. Hey, JC. Recurrent miscarriages with scar tissue. Had a hysteroscopy, waited 2 cycles, now failed cycle 38. How long before I come back and consider IVF? Okay, so recurrent IVF is not a treatment for recurrent miscarriage. What IVF enables us to do is to find embryos that are chromosomally normal. So the one factor that you don't know about when you conceive spontaneously was that embryo normal? And at 38, 6 to 7 out of 10 eggs are going to be chromosomally abnormal, right? So there's a fair chance that a miscarriage could happen because of chromosomally abnormal embryos, which has got nothing to do with scar tissue. So if the hysteroscopy has treated the scar tissue or the Asherman syndrome, fantastic. If your cycles are back to normal, if your menstrual bleed is somewhat normal, if your endometrial thickness has grown at mid-cycle and it's normal, which we sort of call more than, say, about 7.4 millimeters, then that's all happy days. But then the one outstanding piece of information is that embryo that's arriving in the cavity actually chromosomally normal? And that's what IVF does, is it helps you to choose a chromosomally normal embryo. Okay, there's one more question. I'm going to answer it. DSY, what the chance of getting pregnant naturally with a low AMH? All 5 transferred fail, get more eggs. So an AMH is not a measure of your fertility. There's been studies that show that even young women with a low AMH, their pregnancy rate is the same as other young women with a normal AMH. So if you have a low AMH because you're 40 and it's expected that you would have a low AMH, then the reason that you might be having miscarriages or not conceiving is to do with your age, not to do with your AMH. The reason that we value an AMH measure is it enables us as fertility specialists to determine how much medication we need to give you to optimally stimulate you. But if you've got a low AMH and you're getting low egg numbers, then that is expected, unfortunately. We expect to get low numbers because you have a low ovarian reserve. It's just about going through the numbers to find that elusive normal embryo such that you can see. But of course, the one caveat in all of this is that you've got to make sure that all of those other factors that can affect fertility have been accounted for. So, if you have had multiple transfers, recurrent implantation failure, then it's worth your specialist going back to the whiteboard, the blackboard, and going back through all of those factors that can impact on implantation. And if the final answer is, I think it's your embryos, then you have to make a decision how much longer that you're going to continue with this. Do you look at pre-implantation genetic testing, or do you decide at what point you're going to call it quits? Which is a really, really difficult decision to make. So hopefully that has added something, but definitely go back to your fertility specialist and have a chat about recurrent implantation failure. All right, guys, that's it for me today. I certainly think my chemo brain is going, which is fantastic. I had my first Herceptin only treatment, first of 11 more cycles of Herceptin. I feel okay so far. It's not chemotherapy, it's immunotherapy, because I am a HER2 positive breast cancer. So about a decade ago, we didn't have access to this amazing drug. So I'm very grateful that I have been able to have access to Herceptin. I have my surgery in 2 weeks, going for lumpectomy and sentinel node biopsy, putting great faith in my amazing surgeon, Dr. Helen Bilal. And then I'll be going to radiation after that, so 19 sessions of radiation over a month. So I have a little bit of a journey to go. However, I am pleased to say that the really horrible chemotherapy bit is done, and now I can start the road back to feeling a little bit more human again. So I want to thank all of you for your support as I continue on my journey, and I'll continue to share it with you. Okay, everybody, I'll see you soon.